Okay, so let's start. So after headache, in the coming hour, I will talk about movement disorders. So the objective is to able to classify and differentiate common types of movement disorder. I will focus more on the DDX of Parkinsonism. And last, I will focus on the management principles of Parkinson's disease. And Parkinson's disease is the commonest type of movement disorder. So as the name movement disorders imply, movement disorders describe disorder that is characterized by abnormal movements of your body, your limbs, and very easy, we can classify into either fast or slow. So the fast include this action tremor, it's a fast tremor, dystonia, bothersome coronary acidosis, myoclonus, and tics. Tics is more pediatric problem, so I will not mention a lot about tics in this lecture. And the slow, as most of you are aware, is we use this word Parkinsonism. So Parkinson is the surname of James Parkinson, a physician lived in London 200 years ago. So he described a series of cases with very slow movement, with tremor, rigidity, and postural instability. So this word Parkinsonism, actually, we refer to these four clinical features. So Parkinsonism is a syndrome. Versus Parkinson's disease is a disease, and there are other causes of Parkinsonism, which I will mention later. So I will first touch on the fast movement disorder. So first, action tremor. Tremor is a rhythmic movement, okay? And if we use the word action to describe, which means actually it increases with action. So usually if the patient raises up the hands against gravity, then the tremor comes, or during movements, okay? And the tremor persists throughout the movement. It's different to the cerebellar tremor, which is more intentional towards the end, okay, like the cerebellar. But for action tremor, it's quite persistent. Possibly sometimes towards the target is more severe, but even throughout, the patient has tremor. So it's around 4 to 11 hertz. For a resting Parkinson's tremor, it's usually say 3 to 4 hertz. So the action tremor, the tremor frequency is faster. So obviously, if you're in an anxious state, many students during the OSCE short case, they have sweats and they have tremor. So this is an enhanced physiological state. And if the patient have really this persistent action tremor, if this is a first consultation, a new case present with an action tremor, I will check thyroid function test. Even though the patient has no heat intolerance, no goiter, no palpitation, nothing, I will still check a thyroid function, TFT. Okay, this is a golden rule. Any unexplained tremor, you check TFT. Because sometimes for thyrotoxicosis, the only manifestation is tremor, action tremor. So I had a colleague whose sister in her mid-30s present with tremor with no other toxic symptoms. So so I saw her sister, and it looks like action tremor. It looks like the primary essential tremor. But then but we still need to rule out it's not TFT. So I checked the thyroid function. I was so surprised the thyroid function came back to be highly thyrotoxic. Okay, so remember, check thyroid function. Anyone present with action tremor. And of course, I asked drug history. Beta agonist, the Prof with COPD or asthma use will have these side effects, and a sodium valproate and anti-epileptic drug may present with these side effects of tremor. Okay, I mentioned about the cerebellar tremor, and it could be psychogenic. Okay, psychogenic means it's functional, it's not real. So there's this disease which we call essential tremor. Just like essential hypertension means there's no other secondary causes. So essential tremor or primary action tremor is usually bilateral. It's different to Parkinson's. Parkinson's is usually unilateral, one side more severe. But for essential tremor, bilateral, affect the arms, the head. The head will have this nodding, yes, titubation, yes, yes, yes. Okay, always yes. And a voice, oh, it's tremulous voice. So the patient may have this full-blown limbs, legs, head, and voice tremor. It's a slowly, very slowly progressive. It's in middle age, very, very common, like migrant, to have a positive family history, and the treatment is a beta blocker, propranolol. Classical, we use propranolol, and rarely we will perform a deep brain stimulation. So if it's really disabling, the patient have problem with feeding, with writing, with all the basic ADL, then we may consider a deep brain stimulation. We usually stimulate the thalamus. But we rarely perform DBS, but we can. So it's an option, treatment option. In the last 20 years, we performed about 3 DBS upon patients with a really disabling essential tremor, and it's very, very effective for your information. Okay, now we quickly move to dystonia. Dystonia is more sustained muscle contraction, like this. Okay, sustained muscle, but often with twisting. Okay, with some twisting, but it's sustained, repetitive, stereotype, sustained twisting movement, with usually associated with an abnormal posture. And I'm 100% sure that you have seen a patient with dystonia. Classical in the old days is with cerebral palsy, CP, cerebral palsy. Our Paralympics gold medalist, 100-meter dash, So Wai. Okay, he had CP, so like this, but he run very fast. Okay, cerebral palsy. This is a kind of secondary dystonia. So there are other causes, other secondary causes such as drugs, and you had the psychiatry rotation in 5th year. Not sure whether you observe any patients with severe antipsychotic, neuroleptic-induced tardive dystonia. And the tardive phenomenon can be dystonia like this, generalized as retrocolors, as an internal rotation of both arms, classical. So the history will be obvious. Schizophrenic on neuroleptic, eventually develop this tardive, but the tardive commonly affect the oral, the tongue, involuntary, choreic movements. For more advanced Parkinson's disease, during the off phenomenon, the patient, apart from having more Parkinsonism, may have dystonia affecting the toe, usually the foot. Okay. Certain infections, Japanese encephalitis, not common, but it may occur. It may damage the basal ganglia afterwards, causing a residue dystonic posture, and it can be psychogenic. So there are other very rare causes for dystonia, which I won't go into detail, but I just put it down, CDE, dystonia plus syndrome. There's a Wilson's disease, or even Huntington's. Apart from chorea, some may have dystonia. But Wilson's disease is a copper, a problem with metabolism of copper. It will accumulate in liver, causing liver failure, liver cirrhosis. It may also accumulate inside the brain, inside the basal ganglia, causing dystonia, and with KF, Kasha Fleischer ring, and the other causes, very rare neurodegenerative disease or some paroxysmal carcinogenic dystonia, very rare. It's more for the last paroxysmal carcinogenic dystonia when it's a pediatric. Once the kid run, the patient may develop dyskinesia or dystonia. Okay, now I'll talk more on this primary dystonia. It's just like primary essential tremor, but primary dystonia with no other causes, no hereditary, no drug-related, not tardive. So it can affect, in adult, it usually affect the upper body, the face, the around the orbicularis oculi with sustained contraction, causing a frequent blinking, and sometimes severe enough blepharospasm lead to functional blindness. It's so severe, sustained contraction of the orbicularis oculi muscle, the patient cannot see, okay? And it may pose danger when the patient cross traffic. So this is blepharospasm. If it affects the sternocleidomastoid muscle, the patient develops this cervical dystonia. Okay, the sustained muscle contraction affecting the sternocleidomastoid muscle. It can be task specific, a writer's cramp or musician dystonia. If you have friends who are musician, I have a good classmate. There's a musician. He teaches at somewhere, teach people violin. He developed this dystonia of the fingers. Whenever he plays violin, he cannot, with dystonia of the finger muscles. Writer's cramp is whenever the patient write, the cramp, the dystonia occurs like this, okay, affecting writer's cramp. So this is more adult onset. Children is more generalized. It can be a DYT1 as a genetic mutation causing a generalized primary dystonia. Usually for primary dystonia, if you perform an MRI brain, it is completely normal, okay? Just like essential tremor, you cannot scan it. The MRI brain looks normal, okay? But actually the circuits, if we can, certain sequence of MRI can detect the abnormal circuits. This is possible. They will pick up some abnormality in more advanced MRI sequences. But just a plain structural MRI, it looks normal. So the treatment, if it's a more focal blepharospasm or cervical dystonia or even writer's cramp, the first line will be a botulinum toxin injection. But it's symptomatic. The toxin effect will wear off in a few months, so the patient needs regular injection. The other drugs, such as tetrabenazine, is a dopamine depleting agent and an anticholinergic, clonazepam, overall not very effective. The drugs are not very effective, and rarely a deep brain stimulation may help. And we target the globus pallidus. Okay, for the essential tremor, it's more the thalamus. For the dystonia, it's more the pallidus. Okay, the pallidus. So stimulate different basal ganglion nuclei will have different effect. Okay, so first line is this injection. We can try drugs, usually not very effective. Third is chorea. Botulism is a wild flinging, while chorea is in between, it's a dancing. Athetosis is more a very proximal movement. Okay, so this is a spectrum. So the definition is a more irregular, continuous, dancing-like movement, chorea, okay, like dancing. So again, it can be neuroleptic, as I mentioned before, tardive. Tardive means a delayed onset. Okay, usually the side effects of the drugs will happen immediately after you take the drug, such as if it's a vaccination, the allergic reaction will occur immediately. Okay, so if you are allergic to penicillin, the rash may occur within first few days. But for neuroleptic, it's a delayed onset. Tardive means delayed onset. So, and the funny thing is, even if you stop the drug, the side effects persist. So this is tardive, no good. So after a few months, then this involuntary movement may occur classically around the mouth. It may be dystonia, as I mentioned before. And so there's tardive. And even if you stop the drug, switch to quetiapine, if you stop, completely stop, it may persist. So this is not good. And levodopa is a drug for Parkinson's disease. If in the more moderate or advanced stage, once you take the levodopa, the patient may develop dyskinesia. Okay, another cause is if you have a lesion in the basal ganglia, it may induce chorea, hemiballismus. So in our stroke unit, we had about 1,000 stroke cases every year. We had about 4 to 5 hemiballismus. It's not common. It's a strategic infarct. Heating, usually it's a subthalamic nucleus. Subthalamic nucleus, part of the basal ganglia. Then the patient with a sudden onset, usually it's an elderly, sudden onset, not weakness. Contrarily, it's an involuntary movement. So although it's a piece alarming, I will usually explain to the relative and the patient, well, this is a minor stroke because of a very small infarct, but the infarct hit at a strategic area which would cause involuntary movement. Okay, so the other are less common. Very high glucose or even thyrotoxicosis, or very rarely in the pediatric, a streptococcus infection can lead to chorea, or even SLE can manifest as chorea. Very rare, very rare. Unfortunately, in Chinese, Huntington's chorea is not common. It's more Caucasian's disease. And it's a primary hereditary autosomal dominant Huntington's with a dementia and chorea. Okay, and again, it can be psychogenic. And for chorea, the drug treatment is a tetrabenazine. As I mentioned before, is a dopamine depleting agent. And the side effects of a tetrabenazine is Parkinsonism, depression, because it depletes dopamine. So there are other newer generation of tetrabenazine, felbenazine, or delta tetrabenazine not available in Hong Kong. Very expensive, not available. Less side effects than tetrabenazine. Of course, actually, we can even use a typical neuroleptic to treat chorea. But nowadays, we rarely use haloperidol. Because although it may suppress the chorea, it may lead to other tardive movement disorder. At the end, we may consider the deep brain stimulation. We rarely do it for chorea, rarely. We move to myoclonus. Myoclonus is a sudden jerk. It's just like a hiccup. It's a diaphragmatic myoclonus hiccup. Sleep jerks, all of you may have experienced, is when you're on the verge of falling into sleep, you suddenly wake up with a jerk of your leg, okay? Then you wake up and then you fall back to sleep again. So this is a kind of myoclonus. So by definition, myo is muscle, clonus is twitching. Okay, so it's sudden. Actually, when we look for hepatic encephalopathy and hysteresis, we look for flapping tremor. So the flapping tremor we can consider as a kind of myoclonus. Okay, it's a sudden lapse. It's a negative myoclonus, we call this. But there's this positive myoclonus. Okay, as one form is, although it's not common, it's an epileptic. A juvenile epileptic myoclonus can generalize as a type of generalized seizure and a frequent this attack of an epileptic. So many times, if we work up a first ever myoclonus, no obvious secondary causes, we'll do an EEG. Okay. But symptomatic myoclonus is not uncommon. We have, as I mentioned before, hepatic renal failure may have flapping. We have many patients, unfortunate, with arrest and post-anoxic brain damage, and then its A&E develop frequent myoclonic jerks. Nowadays, because of aging society, many Alzheimer's neurodegenerative diseases, many patients with Alzheimer's will develop mild myoclonus. So many times the caregivers may take a video, capture the video of the myoclonic jerks and show it to me during clinic. And I will explain this is this is a myoclonus is relatively benign. If it doesn't affect the patient's ADL, the patient seems okay, then it's okay. We just leave it. It can be a focal nervous system damage. If there's an irritation of the facial nerve because of say a aberrant artery, it may irritate the facial nerve, causing hemifacial spasm. Okay, irregular, frequent muscle contractions. Okay, there's a rare mitochondrial disease we call progressive myoclonic epilepsy. So it's very rare. I just mentioned it. To complete. With very frequent myoclonic jerks, with epilepsy, slowly progressive downhill, maybe wheelchair bound eventually. There's this essential myoclonus, just like essential tremor. We have essential myoclonus as well. And it's usually very benign, and it's usually not disabling. We have a myoclonus dystonia syndrome. Again, it's a myoclonus plus dystonia syndrome. MRI brain unremarkable. We are unsure of the exact etiology. It's very rare. Okay, for myoclonus, we cannot do deep brain stimulation. And the drug we use is more anti-epileptic drug. The first line, we may try clonazepam, we may try valproate, or piracetam, or levetiracetam. Okay, so for myoclonus, it's not tetrabenazine. Okay, for myoclonus, it's more anti-epileptic drug, clonazepam, such as. Okay, now let us move to Parkinsonism. So for your information, in a movement disorder clinic, say if you sit in our movement disorder clinic Tuesday afternoon, 80% of movement disorder cases are the Parkinsonism, and less is hyperkinetic, fast movement disorder, much less. Okay, so if we see a patient with bradykinesia, resting tremor, rigidity, and postural instability, then the DDX is first, it can be primary, 典型 primary Parkinson's disease, Parkinson bang. So Parkinson's disease, you all know, is almost 80-90% is sporadic. Mean age of onset 60, and the prevalence is about 1 in 100 of older people older than 60 years old. It's the second common neurodegenerative disease. But over the years, we managed to find more and more genetic mutation. So 5 to 10% with clear hereditary autosomal dominant or autosomal recessive pattern. And among the hereditary with familial Parkinson's disease, we already discovered known genetic mutation, about 30% with known. Still 60-70%, we still could not find the genetic abnormality. Anyway, but overall, as a whole, majority are sporadic. Okay, but there are other things we need to rule out. Say if the patient has small vessel disease, diffuse multiple lacunes, with a minor stroke, the patient may present with Parkinsonism. We call vascular Parkinsonism. Vascular Parkinsonism rarely will have any resting tremor. Okay, rarely will have resting tremor. So resting tremor is more suggestive of a typical PD. But drug-related Parkinsonism will have resting, we just mimic exactly as a case of typical PD. So what drugs? neuroleptic. Prochlorperazine is an anti-dizziness drug. Metoclopramide is an anti-emetic drug. So anti-dizziness, anti-nausea drugs, and neuroleptic may induce Parkinsonism. But just a word of caution, if the patient is a schizophrenic patient taking neuroleptic, develop Parkinsonism, do not use the word tardive. There is no tardive Parkinsonism. Okay. Drug neuroleptic induced Parkinsonism is completely reversible. You just stop the drug. Okay. And then it's reversed. It's not tardive, it's not delayed onset. Okay. One word about this prochlorperazine mainly, many elderly will take this drug, Stametil is the trade name for chronic dizziness, Meniere's disease, and may develop Parkinsonism. So you need to be aware of, especially say patients on chronic. This drug usually designed for PRN indication, but some may take it every day, and this may induce Parkinsonism. But sometimes even if you stop it, the Parkinsonism decreases, but it still persists. So it may bring out hidden Parkinson's disease as well if we use these drugs. A normal pressure hydrocephalus is with a cognitive impairment. The triad is cognitive impairment, incontinence in urine, and gait disturbance. And gait disturbance may mimic the Parkinsonian slow gait, small step, and postural instability. Okay. The poisoning carbon monoxide, especially after suicide, siltan, okay, and manganese, silhorn, welding industry, may be poisonous and manifest as a Parkinsonism. JAB-B encephalitis, depression may also present as mask face, a very low mood mask face. We can tell from the history. Okay, there are this neurodegenerative diseases, but it's more extensive than the Parkinson's disease. We call Parkinson plus syndrome, such as multiple system atrophy, is plus autonomic dysfunction, cerebellar syndrome, or pyramidal signs with a brisk reflex upgoing plantar. There's a plus impaired vertical gaze. The patient just stared directly, can look right or left, but cannot look up and down, cannot. So they're both eyes only just horizontal movement, no vertical movement, then this is PSP. If it's a Parkinsonism plus dementia, then it's a possible dementia with Lewy bodies. But mind you, before we label this as dementia with Lewy bodies, the patient may also have vascular multiple lacunar small vessel disease, because a small vessel disease can give rise to Parkinsonism and cognitive impairment and dementia. So we need to think about this possibility and arrange a CT or MRI to confirm whether the patient has a vascular lesion. For DLB, the MRI brain in the initial stage usually looks normal. And there's this rare hereditary degenerative disease, Wilson's disease, may have many apart from Parkinsonism, movement disorder may have psychiatric and liver problems. So the movement disorder, not only Parkinsonism, but as I mentioned before, it can be even cerebellar and dystonia, Wilson. So these are the DDX we need to think of. So if you encounter the first case, you should ask about different things. So there is a patient on this neuroleptics or anti-dizzy and anti-nausea drugs, whether the patient has a postural dizziness, a drop in blood pressure, and you check the patient gaze. You should also do a cognitive assessment. And okay, so these are the few things. So this is a KF ring, okay, in the cornea, in the peripheral. This is brownish discoloration. Okay, brownish discoloration. So if you encounter a young onset Parkinsonism, remember the golden rule is to rule out, is not rule out TFT, thyroid function, it's to rule out Wilson's. Young onset Parkinsonism, you rule out Wilson's. So you check for serum ceruloplasmin. Okay, ceruloplasmin is copper binding. It will be very low in Wilson's. You should save 24-hour urine for copper. You may, so if you confirm it's Wilson, you should also check your liver function and do ultrasound of the liver and the liver cirrhosis. Okay, so this is Wilson's disease. So young onset. If this is a short case, apart from the traditional physical examination, you look for resting tremor, look for rigidity. It's a resting tremor. You check for rapid alternate, whether it is clumsy with Parkinsonism. Okay, you should also look for KF ring. You should also check for cognition, ask for any drug history, especially neuroleptic, antidissonant, anti-emetic, anti-nausea drugs. And you check for postural blood pressure. So you should tell the examiner all this. Okay. This is an MRI for severe small vessel disease with vascular Parkinsonism. Okay, with a white matter hyperintensity, diffuse white matter hyperintensity on FLAIR image, and with multiple lacunes. Small lacunes is a small vessel disease, usually with a minor stroke, a lacunar stroke, the weakness about 4 or 5, but the patient may present with bradykinesia, cognitive impairment as well. Okay, this is a small vessel disease problem. Okay, so after the DDX for Parkinsonism, let's focus on the treatment. Now, first of all, if you encounter a patient who complain of say resting tremor, very slow movements, then you decide whether the features are typical for PD or not. So atypical features may include very young age, the patient may have recurrent stroke, the patient may have impaired vertical gaze, severe autonomic dysfunction at the onset of the motor features. Okay, these are all atypical features. Dementia at the onset, not typical. Okay, if it's more symmetrical, it's also not typical. But for MSA, it's more symmetrical. Okay, so if the patient has early gait disturbance with a recurrent falls at the onset, this is not typical. Okay, but for multiple system atrophy, for progressive supranuclear palsy, it's a frequent early falls. Okay, the patient is on neuroleptic, dopamine receptor blocking agents, then we need to think about drug-induced. Okay, so if the patient is classical, say if the patient is a 55-year-old male, male is slightly more common, it's a 1.5 times, 1.5 times to 1. Male is slightly more common, 1.5 times, and than female. So if it's in the right age and with a one-side resting tremor, a classical bradykinesia, and rigidity, very typical, no atypical features, then usually I'm happy, no need to do any whatever neuroimaging. Okay, but in case of you're not sure, then we can consider an MRI first, and then we can do some dopamine transporter SPECT imaging. I won't dwell on this, but for a typical case, no need. Then what drug, what should we do? We can then discuss with the patient. Then there is this monoamine oxidase B inhibitors, MAOB inhibitors. First generation is selaginine, and the second generation is rasaginine. Slightly less side effects, slightly more expensive, because there are evidence from past literature that the MAOB inhibitors may be neuroprotective. Okay, so I may consider use of this. Uh, Although the evidence is not 100%, but it has some evidence. So if I have Parkinson's disease, I will consider use of selaginine or rasaginine. If I can afford, I will use rasaginine. And so over the long term, the progression may be less. Okay. And then I will give advice. You can do play Tai Chi, aerobic exercise, not overdo exercise, okay? But some exercise is good. Anyway, so if the disease continues to progress, okay, I will advise all this, but I will ask whether the symptoms, the Parkinsonian symptoms, affect the patient's daily functions. At work or at home, in basic activities of daily living, can you do it independently? Does it affect your work? If the patient said yes, it started to affect my work, then we should consider medication. If no, then we can still give selaginine. Selaginine or rasaginine has some symptomatic effects. Say 10, 15 or 20%, it will reduce the Parkinsonian signs of tremor, rigidity, bradykinesia, but it's not dramatic. Okay. Anyway, so we can observe, we can do nothing. If it doesn't affect the function, it's okay. So for me, during the consult, I will ask the patient, hey, you have yeah, I could observe your tremor, your walking is a bit slow, but I will ask, does it affect your function, your ADL, your hobby? Do you need anybody to help you? Okay, so this is how I will ask questions. If the patient is retired, he said, no, it's okay, I can cope, I accept, then it's okay, you can just observe. But if the patient said, yes, I would like, it's really annoying, the tremor very embarrassing, I don't like it, okay? And if it really affects you in the buttoning, in the writing, in whatever ADL, then you really want some medications to reduce the symptoms. Then we can consider, and it will depend so what drug to use. We have many Parkinson's drugs. So it's if the patient is young, say younger than 70 years old, then it will be, and the symptoms are not very severe, but still disabling. Then we call dopa sparing strategy. Do not use levodopa. We can try MAOB inhibitors, as I mentioned before. We can try amantadine. We can try dopamine agonists, DAs, dopamine agonists. We can try amantadine, anticholinergic such as artane. Okay, artane, anticholinergic, especially good for tremor. So nowadays, we try dopamine agonists for younger subject with very mild to moderate disabling symptoms. So we try dopamine agonists first, okay, to control the symptoms. Okay, but if the patient is already quite old, 70 years or older, then we will be less restrictive. We can use levodopa. The reason for this is if we use levodopa at a young age, at a high dose, it will easily induce the drug-induced dyskinesia. Okay, but for older people, it's less a concern. It's a more concern for older people. And for older people, actually, dopamine agonists will have more side effects in older people. It may easily more likely to cause, say, nausea, dizziness, and more alarming is a visual hallucination. Okay, so I would tend to use a levodopa first for older people for disabling symptoms. And so overall, in clinic, I will monitor side effects. I will ask about how it affects the ADL. I will ask about other non-motor complications, which I will talk about. And if needed, I will refer physio if the patient has a risk of fall affecting ADL. I refer to OT, occupational therapist, swallowing, dysphagia, aspiration risk. I will refer to speech and sometimes very soft voice. There's some speech therapy which may increase your phonation in Parkinson's disease. I will ask about, will check chat with the caregiver, any stress as they live with a patient care for a patient with Parkinson's disease. So these are things that I would do in the clinic. Okay, so I will use levodopa for younger person if dopa sparing drugs fail to control disabling symptoms. And I will use the lowest possible dose of levodopa. And usually, say, after 5 years down the road, the patient may develop some motor complication we call peak dose dyskinesia and wearing off. So like a wave. So usually I will use the Chinese word 波浪期. Okay, I will rarely use the word 後期。你有後期柏金遜所出呢啲咁嘅副作用 ？No， 後期 sounds scary like a cancer. So you have reached this 波浪期啦。食咗藥就會好啲，藥散就會差啲。食咗藥有時有啲不自主，藥散就會差啲。So this is what we call the motor complications commonly associated with levodopa. So if that is the case, you should definitely refer to neurologists at this case, at this stage, okay? Because the titration of medication is very complicated. Okay, I won't talk about this in this final year lecture. But eventually, for us specialists, if after titrating all the drugs, some may in the Western countries, they have this infusion, levodopa intestinal gel infusion. I will briefly mention this later. So, but in Hong Kong, it's mostly we'll try deep brain stimulation, targeting ST and subthalamic nucleus. Okay, so this is an algorithm of a treatment for Parkinson's disease. Now, this is what I call the motor complications. So, in the early first 3 to 5 years, even if you take levodopa, BD, or twice or 3 times a day, the effect will be very smooth, very smooth. There's no change throughout the day. Okay, but eventually, say 5 years down the road, 50%, 50% may develop some of this motor complication, usually wearing off first. So say 4 to 5 hours later, the symptoms will re-emerge. Okay, so the patient, it will remind the patient to take the second drug, a second dose, and the symptoms subside. Okay, so with disease more advanced, the patient may develop peak dose dyskinesia, chorea-like movement. So eventually, the patient may develop this swinging, on with dyskinesia and then off, on and off, on and off. So this is what we call the motor complications. There are other disabling symptoms which are less reversible by drugs, such as freezing gait, 冰冷步. Fascination is the center of gravity is always appear to be at the front, so the patient keep 追住走 and cannot stop. So the patient may bump into walls with fascination. Postural instability is when you pull the patient may fall easily. Okay, these are other motor phenomena. So in this, with motor complications, we can titrate medications, we can do deep brain stimulation. There's this injection, apomorphine injection. Apomorphine is a dopamine agonist, a liquid form. So if we can do it like subcutaneous, like insulin, if the patient develops suddenly off, if the patient develops off in the street, outdoor, then this apomorphine injection is a rescue injection. Okay, so the caregiver can give a subcutaneous injection of apomorphine and wait after, say, 10 minutes, the patient will wake up and can move, and the effect lasts for, say, an hour. So we have an hour time for the patient to go back home. There's also a continuous infusion during daytime, so it will level off this bolon, this fluctuation. But we tried this in some patients. The patient did not feel comfortable, and this apomorphine infusion in Hong Kong only available in Queen Elizabeth Hospital. So if specialists think that the patient need this, then we will refer to QEH. And this is the levodopa. Now, apomorphine is dopamine agonist. For levodopa, usually it's a tablet oral formulation, but now we have this gel form, which we can do kind of an OGD and put a PEG, and the PEG will infuse this gel form levodopa continuously into the duodenum. This will also level off the fluctuations, okay? But we do not have this in Hong Kong. So 100% for exam, we will not ask this in exam. Okay, deep brain stimulation, and so we usually target the subthalamic nucleus. Is we in Chinese we call it's a 腦起搏器, not the 心臟起搏器. So it's a pacemaker for the brain. Okay, and we are one of the leading center in whole of Asia because we performed this first DBS in Asia in 1997, and we published our 12 years experience many years back. And so the good candidate were those with this fluctuation, swinging, okay, and severe dyskinesia, swinging. But actually, the contraindication of those who were demented, who had severe autonomic dysfunction, suggestive of other diseases, MSA, and poor dopaminergic response. What I meant by poor dopaminergic response is for PD advanced, the dopamine, cinemats, dopamine agonists, levodopa, medopa, can still induce a good response, but it's just that the response lasts only briefly, okay? So if that patient, even if we give a high dose of levodopa, the patient could not develop this own response, then this is not a good candidate for DBS, okay? Major psychiatric disease, or absence of caregiver, these are contraindications. So if we do the DBS, afterwards, this high swingings will be leveled off by the afterwards by DBS. Okay, the patient, because after DBS, we can reduce the medications. Because of reduction of medications, the on dyskinesia reduce. And then even if we reduce the drugs because of the DBS effect, the off will not be that low. So the patient will be at a good on state without dyskinesia and without severe off after DBS. So this is a good thing about DBS. But usually DBS cannot help many non-motor manifestations. It's also symptomatic. The disease will continue to progress. The patient, we had cases of DBS, say 10, 15 years after DBS, the limbs effects very good. The patient could walk to the clinic without aid, but the patient developed dementia, okay, with dementia. So, and also many exile symptoms such as speech and swallowing, DBS effect is not very good. So there's this autonomic problems, DBS will not help. And obviously, DBS will not help the mood, It may have the mood if the mood problem is because of severe motor symptoms. Okay, and it's a delusion, it may not help. Okay, so for Parkinson's, it's more systemic disease. The patient may have blurred vision because even the ocular muscles, the controlling the consensual eye movement may be impaired, leading to the poor focus, blurred vision, loss of smell, sensory symptoms in the limbs, fatigue, autonomic dysfunction, constipation, sweating, incontinence of urine, impotence, and speech and swallowing problems, sleep disturbance, including REM sleep behavior disorders, hallucination, delusion usually is drug related, and dementia. So these are all we call non-motor symptoms. And I put a red are those who may appear before the symptoms of motor. Before tremor, because bradykinesia, we call premotor symptoms. So this include the loss of smell, REM sleep behavior disorder, constipation, and depression. So these four are common premotor symptoms, usually preceding 5 or 10 or 15 years before the development of motor symptoms. So we call premotor. Okay. So it is possible that we can detect a very early stage of Parkinson's disease by these symptoms. And if one day we have some neuroprotective therapy, we can actually intervene early, even before the onset of motor symptoms. So let me show you this. So can students see this video? Okay, thank you. So it's one-sided tremor, resting, affecting the leg, predominant right side for the tremor. So this is typical for Parkinson's. It's asymmetrical. Kind of a mask face. Even the tongue movement was affected. Well, this Parkinsonian resting tremor also has a postural component. I asked the patient to do this finger tapping, rapid, but it was very difficult for him. And open and close as quick as possible. But that was what he could do. Asked him to do this rapid alternating movement, finger tapping, difficult. Ask the patient to open as wide as possible and tap as quickly as possible. Now it seems the tremor was less severe with this upon movement. Not much intentional cerebellar component, okay? There was some intentional tremor. So I used to, this is test the agility of the leg movement, to use your heel to lift it up a few inches and to tap the floor as quickly as possible. Very difficult for the right leg. Very difficult. He could not even raise up the heel. So he just do this tapping. And this was not what I instructed. I asked the patient to lift it up and tap. I asked the patient to arms fold and to stand up. Okay, he could do it. Slowly, you could do it. This was a video I took 15 years ago. Uh, kind of a still posture. That was me many years ago. And I was testing the postural instability. So the patients need to stand, legs slightly apart, but not one. Oh, so this is impaired. So quickly pull, the patient fell. Okay. So small step, I ask the patient to turn, the patient freeze. The patient tried to turn but could not. So this is freezing gait. And what I just did was posterior pulling. It's a postural instability, freezing gait, the legs glued to the floor. Could not make turning, difficult to initiate the first step. So this is more freezing. So I hope you can appreciate the freezing phenomenon. And also the postural instability. And the instability was not due to proprioceptive loss, not due to cerebellar problem, not due to weakness. Okay, this is about 15 minutes after intake of a Cinemat, 250 milligram levodopa. So now the patient is now at the on state, on with dyskinesia. So I asked the patient just to stand still, but the patient could not. It's an involuntary movement, like dancing. Okay? He was trying to stand still, but he could not. This was a dancing choreo movement. So it seems there was a background music. Okay? But no, the patient. This was our chief neurosurgeon, Dr. Danny Chen, many years ago. So this was the on. So we were assessing this patient for DBS. He had 10 years of Parkinson's disease at the age of 67. Okay, so at the on state, so this is a good dopaminergic response, but it's just that it was not smooth with a dyskinesia. Okay. Now, I would also like for Parkinson's disease, apart from the drugs, non-pharmacological, apart from the DBS, I would like to remind all students that you read this slide. It's published in Science many years ago. It's for patients randomized to a Parkinson's disease trial. Even for subjects who receive placebo, if the subject believes that the placebo is a good drug, it will induce release of dopamine captured by a PET record cloud, PET imaging. Okay, so my point is, if you give hope to Parkinson's patients, 柏金信，信 is 信有明天啦 ，OK。Remember, Parkinson, give hope to the patient. The patient may feel happy, okay? And if the patient feels happy, the patient will say, then the patient's symptoms will improve. So I tell one story. When I was in my overseas training in movement disorder in Columbia University in New York, that was in 2000. Okay, in 2000. That was many years ago. I was in New York in Presbyterian. And that time they were doing fetal transplant of dopaminergic neurons from the fetus. Uh, that was not ethical now, but they still did it many years back, and they implant into the striatum of the brain. And initially, it was a placebo double-blind study. So actually, some patients received the real uh, dopaminergic fetus dopaminergic neurons. But the other group just received normal saline. The neurosurgeon just squirt in some normal saline. And so after the surgery, the assessor didn't know and the patient didn't know whether they received the actual cell or the normal saline. So one patient joined this study after the surgery. She believed she received the real dopaminergic cells inside the brain, and her signs and symptoms completely subside. And she was interviewed by a TV program, and she said, "Wow, this transplant cured my Parkinson's disease." Okay, so dramatic. But eventually, at the end of the study, this subject was unblind, and actually, that lady received the normal saline. Okay, so this case actually illustrates that the positive placebo effect for Parkinson's is very substantial. So usually for me, if I see Parkinson's, if you in the future see Parkinson's patients, you need to be very positive, be nice to the patient, always encourage. Okay, always encourage rather than scold the patient, you're doing bad. Then this is very important. Now, I heard comments from patients that after seeing me, the symptoms improve for a few months. But if they saw another doctor, the symptoms increase despite increasing drug. Okay, that's the end. So, any quick question? Okay, now if with this arms fold and the patient stand up, this is the test for truncal mobility. This thing will depend on the truncal muscle, bradykinesia, and rigidity. If the truncal muscle, the truncal part, the more axial truncal part was very severely affected, bradykinetic and rigid, the patient could not do it. It also tests a bit of the legs power as well, but for me, it's more the truncal mobility because Parkinson's also affect the truncal muscle as well. Okay, any other question? Okay, thanks, Gabriel. Okay, so I hope you pick up something useful from the headache lecture. It's a very practical lecture. And also for this Parkinson's lectures, I'm sure you will encounter Parkinson patients in your lifetime, even if you are not doing Parkinson's, because it's very common disease. Especially we expect these Hong Kong society will continue to age in the coming decades. Okay, thank you. If you have other questions, you can email me. Okay, all the best with your final year at all. Okay, bye-bye.